Good day, everyone. Thank you for attending our second webinar for the Cardiac Critical Care Fellowship Program. This is Dr. Ashwag. Today, I will just give a brief of introduction of our program and what is our view and vision. So it is a unique program. Duration, it will be 1 year with a structure of 3-module asynchronous audio-video lecture. The module duration, each module will be 16 weeks, including the exam. With the module outline, it will be dictated lecture reflecting the practice on international guidelines. MCQ with the answer and explanation will be provided. Case discussion and critical abrasion of scientific paper. Review publication with recent publication beyond 2022. We have international subspecialized speaker from the Gulf area, from the North America, and from Africa and India. It will be, we have the multidisciplinary expert team with the cardiac critical care, as well as from cardiologist, electrophysiologist, echocardiographer, and cardiac anesthesia, cardiac surgeon, advanced heart failure team, and in addition of perfusion. So those are the board member of our program, which is the internationally with diversity. So upon completing the program, you will be expected to receive American Accreditation Association certificate, knowledge how to deal, troubleshooting the mechanical circulatory support, mastering the management of cardiac critical care patient. So our starting date, it will be 1 September, and our graduation date, it will be mid of August. Feel free to ask any question through our website or through the email, either me or Dr. Hijazi. We are willing to answer. As well, you can share through the chat and we will answer in the chat. Thank you. And the mic is back to you, Dr. Hijazi.
All right. So thank you again, everybody, for joining. And what I'm going to share with you here is a strictly online educational program under the World Institute of Critical Care and Emergency Medicine. And we've called it the Cardiac Critical Care Fellowship. I would say this does not replace clinical training, but it certainly augments your knowledge and helps you prepare for your exams, and basically is an investment in your career, in your long-term career. So we've divided our online educational program into 3 modules. The first module we've called the Foundations of Critical Care. The second module we've called Perioperative Cardiac Care, which is the bulk of the program, because most of us do take care of post-operative patients, and that is really what we're signed up for when you sign up for your fellowship. The third module is Mechanical Circulatory Support, and that's where we cover all the MCS topics. So let's start off with the Foundations of Critical Care. The Foundations of Critical Care, as you can surmise, basically lays the foundation for the online educational program. We discuss applied cardiovascular physiology, pharmacology. We talk about monitoring. We talk about critical care management of cardiovascular emergencies. We talk about left and right heart catheterization, how to read a left and right heart cath. And then we cover ultrasound with a lot of focus on TEE, because we tend to be very heavy on TEE in our program. In cardiac critical care specifically, TEE has a major role to play, because a lot of times you have dressing on the chest, you have subcostal chest tubes, you're not able to get good views with transthoracic imaging. So in that first module, we do cover a lot of TEE related to the cardiac ICU population. And then we move on to module number 2, which is perioperative cardiac care. And that's where we start covering the intraoperative aspects of care, the basic surgical steps, just the need to know stuff for you as an intensivist to be aware of what happens in the OR. And then we go into basic post-op care and post-operative complications like perioperative bleeding, tamponade, low cardiac output, myocardial infarctions, RV failure, post-cardiac surgery vasoplegic syndrome, dynamic LVOT obstruction, cardiac arrest post-cardiac surgery, arrhythmias post-cardiac surgery, pacemaker troubleshooting, and then care for specific patients like the post-heart transplant patients, lung transplant patients. We talk about neurologic complications after cardiac surgery. We talk about delirium. We talk about management of a specific entity of patients, and that is PE, or pulmonary embolism patients. And that would be basically module 2. And then we move on to module 3 of our curriculum, which is the mechanical circulatory support module. And that's where we cover VA ECMO, because that's mainly what we use in the cardiac surgery ICU, but we also have a week of covering VV ECMO as well. And we cover balloon pumps, Impellas, left ventricular assist devices, and RVADs. And that takes us to mid-August. So it's a comprehensive curriculum that covers basically all what you need to know about cardiac critical care. We start in September, and so please feel free to visit our website, the landing page of our website, and we've also very recently created a WhatsApp group for the fellowship program. And so today, what I'll be talking to you about is really just temporary mechanical circulatory support in the cardiac surgery ICU. And what I'll mainly cover is some of the recent publications that may or may not change your practice. And these are all publications that have come out in the past 2 or 3 years that have been quite important for us to be aware of. And some of them may actually change your practice. So let's jump right into it. These are my disclosures, none of which are related to this talk in any way. And so what I'm going to be talking about is, as I said, publications related to mechanical circulatory support. And the first one is going to be related to VA ECMO. The second is going to be related to microaxial flow pumps, which is the proper name for Impellas. The third publication I'll cover will be a publication that came out recently that tried to answer the question, how do we, or should we all unload the left ventricle early enough with VA ECMO, or should we just do a watch and wait approach? The fourth study that I will share with you is related to anticoagulation on ECMO. And so let's start with the first one, and that would be the RCT that was done on VA ECMO, quite an important RCT. And we use VA ECMO in cardiogenic shock patients for a multitude of indications. We use it in patients with acute myocardial infarction, myocarditis, cardiac arrest, post-heart transplant, LVADs, post-cardiotomy. And so there are quite a few indications for using VA ECMO. However, the study that I will be talking about really just looked at the use of VA ECMO in patients with cardiogenic shock due to an acute myocardial infarct. And so that was their inclusion criteria for this particular study. And so this is the ECLS shock trial, and this came out in 2023. Basically, it came out in the New England Journal, the Extracorporeal Life Support and Infarct-Related Cardiogenic Shock. It was a multi-center randomized control trial in Germany and Slovenia. As I mentioned, they included patients with acute myocardial infarction complicated by cardiogenic shock. They mainly included SCAI class C, D, and E cardiogenic shock, patients with a lactate of greater than 3, patients who had a planned early revascularization, either by PCI or CABG. They excluded patients who required CPR for more than 45 minutes. However, I must say, anybody who required CPR for less than 45 minutes still fit inclusion criteria. And we've all seen patients who come in with cardiogenic shock due to acute MI, they arrest, they require CPR for half an hour, and their neurologic prognosis is still questionable. These patients were actually included in this study. And so you can think of these patients as a patient population where the neurologic outcome will really dictate their overall prognosis. And so these patients were actually included in this study. Patients who required CPR, any patient who required CPR for less than 45 minutes was included in this trial. The intervention was insertion of peripheral VA ECMO while in the cath lab, in addition to standard medical management and their early revascularization therapy. And they compared that to medical management alone without the insertion of peripheral VA ECMO in the cath lab. The primary outcome was death from any cause at 30 days. And what they found was that there was no difference in the rates of death from any cause at 30 days between those who got ECLS or VA ECMO in the cath lab while they're getting their revascularization versus the control group who just got the PCI without extracorporeal life support. However, there was about a 10% crossover rate. From the 200 patients, about 22 patients in the control group did actually end up receiving VA ECMO, and about 17 patients in the intervention arm, in the VA ECMO arm, actually ended up not getting VA ECMO. Some of them died before getting VA ECMO. Some of them had challenges in establishing VA ECMO. And so there was about a 10% crossover rate, which is, in my mind, quite acceptable. And they found no difference at 30 days. When you look at the subgroup analysis, there was really no difference between the subgroups, although I couldn't help but notice that patients who were sicker with a lactate of greater than 6 millimoles per liter had a bit of a trend towards better outcomes with VA ECMO. Those who had a lactate less than 6 had a bit of a trend towards better outcomes with control, although none of this reached statistical significance. So really just, hypothesis generating at this stage. No real conclusion can be made other than there is no difference between early VA ECMO in patients with AMI and cardiogenic shock. As you would expect, patients who had VA ECMO had higher rates of moderate to severe bleeding, and patients who had VA ECMO also had higher rates of peripheral ischemic vascular complications warranting interventions, quite expected. But the major conclusion that we could take from this study is that early unselective employment of VA ECMO in patients presenting with cardiogenic shock due to an MI with planned revascularization did not improve mortality at 30 days. And so we still don't know. Is there a selected subpopulation that may benefit? Maybe the sicker patients would benefit. We don't know. This study, in my mind, actually raises more questions than it gives us answers. Let's move on to the next study that I'm going to talk about today. And that study is a study of microaxial flow pumps, which is the proper name for Impellas. And for those who want to know where the Impella stands with regards to our armamentarium of MCS devices, the Impella is purely an LV support device. And what I'm showing here is a decision algorithm when you should use the Impella. The Impella should only be used if you have an isolated LV failure. If you have any significant RV failure, Impellas do not support your RV. If you have any significant respiratory compromise, then Impellas cannot support your respiration. And so the Impella is strictly a device for isolated LV failure. If you have RV failure dominant cardiogenic shock, then there are RV support devices that you can use, like the Protect Duo and the RP Impella. If you have biventricular failure, then you're likely better off with VA ECMO. And if a patient has a cardiac arrest, you're certainly going to do better, or you're better off with VA ECMO to support both the cardiac and respiratory systems. How do Impellas work? For those of us who are not familiar with Impellas, Impellas basically sit inside the left ventricle. They suck blood from the left ventricle and propel the blood into the ascending aorta. And I always like to teach my residents, it's like essentially putting a straw down the LV, sucking out the blood, and pushing it up the ascending aorta. And that achieves a lot of benefits. It improves your systemic forward flow. It improves your coronary circulation. It reduces your LV distension, reduces your LV basically diameter. It reduces myocardial oxygen consumption of the LV. And so it has a lot of benefits. And so this is just a TE of an Impella and how we guide its placement. Here we're coming down the ascending aorta, approaching the aortic valve. Here our wire is beyond the aortic valve. Here we've gone right into the LVOT. And then here we have it directed downwards into the LV, just where we'd like it to be. We would typically at this point freeze the screen and measure the distance from the aortic valve down into the LV and make sure that it's sitting comfortably in the LV. Here we can say it's sitting 4.5 to 5 centimeters. And then we do an X-ray, gives you a rough ballpark of where the Impella is sitting, but really it is an echo-guided intervention. And then this is your Impella screen. It gives you a waveform of the aortic root. So it gives you an aortic pressure in red. It gives you an estimated left ventricular pressure in white. And the green line is just the motor power on the Impella screen. And so the study that I'm going to talk about today is a study that used Impella CPs. CP starts for cardiac power. Excuse me. So Impella CPs are usually put in percutaneously by interventional cardiologists. And so this type of Impella is the type that they used in this study. And this is a study that came out in 2024 last year. and it's called the danger shock trial. And people like to say danger shock trial, but danger is probably more accurate because it was Danish-German, and the danger stands for Danish-German. And that was a study that was basically started off in Denmark and then recruited patients in Germany and then subsequently recruited patients in the UK. Now, what they included was patients with STEMI-related cardiogenic shock. And so patients who presented with STEMI, cardiogenic shock, lactate more than 2.5 were included. Any patient who was comatose after a cardiac arrest or a patient with RV failure was excluded from the study. And so that was a pretty smart move on their part when they designed this study. They want to assess mortality in the two arms. Mortality in patients who sustained a cardiac arrest and are comatose after a cardiac arrest is usually related to neurologic prognosis. So they excluded patients who were comatose after a cardiac arrest. And they excluded patients obviously with RV failure because Impellas do not support your RV. And the intervention arm had an Impella running for more than 48 hours at the highest possible performance. And the control group had standard medical management, and MCS support as needed was allowed in the control group. As I said, they started off in Denmark, and it looks like they were recruiting in Denmark well, but they weren't really achieving their recruitment rates, pretty slow. They wanted to get the study done. So they started in 2013, and then they moved on to include and recruit patients from Germany in 2019. And because of their narrow inclusion criteria, they wanted to finish the study. So they also started recruiting in the UK, but most of the patients in the study were between Denmark and Germany. And what they found was that death from any cause at 180 days was much lower in patients who got an Impella, with a significant p-value of 0.04. You can see here that the mortality at 180 days was better in patients who had an Impella presented with STEMI and cardiogenic shock. In composite cardiovascular events, there was a difference in favor of actually the Impella in this study as well. And that includes the need for mechanical support, cardiac transplant, death from any cause. It was all better and all in favor of the Impella. In terms of the subgroup analysis, nothing really jumped at us here. But as you can imagine, patients who got an Impella had ended up having a higher incidence of severe bleeding, limb ischemia, hemolysis device failure, and worsening aortic regurgitation, which is expected when you put an Impella in. Renal replacement therapy was actually higher in incidence in patients who got an Impella. You can see here, and it was statistically significant. And why that is, why did patients with an Impella have a higher incidence of requiring renal replacement therapy? There's multiple theories there. Maybe it's the hemolysis caused by the Impella, maybe that they survived better, and this a bit of a survival bias came into play here. And so their conclusion from the study is that the routine use of microaxial flow pumps or Impellas with STEMI-related cardiogenic shock reduced the risk of death at any cause from 180 days compared to standard care alone. Now, mind you, this is a guideline-changing study. When you actually have a positive study that shows you a survival benefit in this way, this is a guideline-changing study. The next publication that I'll go through, and that covers LV unloading with VA ECMO. And just to give you a bit of a background, VA ECMO, even though it supports your circulation, it increases your afterload. Your LV distends because you're pumping blood into the systemic circulation, into the arterial side, and the LV finds it harder to pump forward against the returned blood from the peripheral VA ECMO. And so peripheral VA ECMO actually increases your afterload, and they actually may make it harder for that LV to recover over time. On the other hand, the Impella and balloon pumps, they reduce your afterload and they help the prospects of the LV recovering, at least theoretically. And so how do you monitor for this increased afterload effect and for this LV distension that can happen with VA ECMO? As I said, the LV may struggle a bit to pump forward against that increased afterload because of the VA ECMO. And so how do you know that your LV is now starting to struggle and that you're starting to experience LV distension? I will classically look at 5 things to say, okay, now this LV is distending too much. We need to intervene here to unload this LV. And what are these 5 things? These are 5 monitors. Echocardiography is the one that I depend on most, And if you start seeing an LV that's distended, there's smoke in the LV, the aortic valve is not opening, it's closed for the most part, and there's dense spontaneous contrast building up in the LV, that tells you that you need to intervene to unload that LV. Chest x-rays, if you have interstitial edema, will be worse. If you have LV distension, you start seeing the back pressure effect. If you start seeing a CVP that's climbing more than 20, a pulmonary capillary wedge pressure that's climbing, if you start seeing a very narrow pulse pressure on our arterial line, all of these are indicators that intervention is required to unload that LV in the setting of peripheral VA ECMO. So look at the echo, look at the x-ray, look at your CVP, your PA catheter, and your arterial pulsatility. Now, when you do start seeing that LV distension is happening with VA ECMO, then LV venting should be immediately addressed in order to achieve some degree of myocardial protection and improve the chances of weaning and that LV recovering. LV venting may be obviously non-invasive or invasive. Now, non-invasive LV venting or unloading of the LV includes just reducing your ECMO flows, giving a chance for that LV to pump forward, reducing your afterload a bit. You can start inotropes to improve contractility of the LV. You can run peripheral vasodilators if your pressure tolerates it. You can increase your PEEP. You can add on diuretics. All of these are non-invasive measures to unload the LV. There are invasive measures to unload the LV. And in order to unload the LV, you need to drain one of three places. And what are they? So you need to either drain the LV directly, or drain the left atrium, or drain the pulmonary artery, because eventually the blood going through the pulmonary circulation will go back to the LV. So you drain one of three places when you're unloading the LV. And there's quite a few options you have here to vent or unload the LV. And these include putting in an Impella to suck blood out of the LV, putting in a balloon pump to reduce your afterload, putting in a transseptal atrial cannula in the cath lab, and draining the left atrium. This will also unload your LV. And this study that we're going to be looking at here, the early unload study, looked at early unloading by putting in a transseptal atrial cannula in patients on VA ECMO. This is the early unload randomized controlled trial. It tried to answer the question is, should we preemptively unload that LV on VA ECMO, or should we just watch and wait and see if that LV distends over time and then intervene? It was a single center RCT in South Korea. They looked at adult patients with cardiogenic shock requiring peripheral VA ECMO. Their intervention was early routine LV unloading with the transseptal left atrial cannula within 12 hours from randomization versus the conventional approach. The conventional approach would be the watchful waiting approach, where they would allow patients to be monitored and then get potentially a rescue transseptal left atrial cannulation or an atrial septostomy in case they start monitoring and seeing that there's an increased LV afterload. So that was their comparator arm, early versus watch and wait. Primary outcome was death from any cause at 30 days. They did not find any difference in outcomes, and the crossover to rescue transseptal left atrial cannulation was very high. This was quite disappointing in the study. When you have a study that is comparing early aggressive unloading versus watching and waiting, the watching and waiting arm, 50% of that watch and wait arm actually ended up getting an LV unloading intervention in the first 24 hours. A 50% crossover rate is really high. And not only that, that crossover happened in the first 24 hours. And so 50% of patients who were supposed to get a watch and wait approach ended up getting an atrial septostomy in the first 24 hours, 50% crossover. So really very hard to interpret this study. How can you interpret this study when your control arm or half of your control arm actually got the intervention and got it early on? There was no significant difference in the outcomes, but obviously, you know, this is very hard to interpret when you have such a significant crossover rate. And so we're back to square zero. This study actually did not answer the question because, as I said, the crossover rate was so high, it's really hard to interpret. And so there's no consensus on this at this stage. The jury's still out. Should we be aggressive early on or should we watch and wait? My approach at this point is still to closely observe and watch and wait, but I pretty much do point of care echoes almost daily in these patients and monitor for LV distension before intervening. And that may be a reasonable approach. As I said, there's no consensus, but that, you know, is a reasonable approach at this stage until we get a more interpretable RCT published. Last but not least, I will talk about anticoagulation on ECMO, and this is certainly a study that I will show that actually has affected my practice quite a bit. So this was a comparison of anticoagulation strategies in patients on VV ECMO, comparing standard heparin versus bivalirudin as the primary anticoagulant. Now, bivalirudin, for those who don't use it as often, is a direct thrombin inhibitor, and it has a 25-minute half-life in patients with normal kidney functions. With patients with renal impairment, it has a longer half-life. But if you have normal kidneys, 25 minutes is your half-life for bivalirudin. It affects your PTT primarily, even though artifactually it'll increase your INR. But really, what you monitor with bivalirudin is your PTT. That is how it affects your coagulation cascade. You monitor your PTT, and you want a PTT that's 1.5 to 2.5 times baseline. Usually don't give a bolus. Usually in the ICU, at least, we just start with a infusion rate, and we adjust to a PTT that's 1.5 to 2.5 times the normal values. If you're using bivalirudin in the OR, then you need to adjust your ACT tubing that you're using. Usually we use either the Kalen ACT or the Max ACT. However, in the ICU, we usually don't monitor bivalirudin effects with the ACT. We usually monitor bivalirudin effects with just the PTT. So this study was actually a retrospective cohort study, but it actually did affect practice. This was a single center retrospective study in Pittsburgh, and they looked at anticoagulation with bivalirudin versus anticoagulation with heparin as their control arm. And their outcomes was longevity of the ECMO circuit. How long did it take for the ECMO circuit to start developing thrombotic complications? Major bleeding events and blood product administration were also looked at as outcomes. And what they found was that the probability of developing a clot was lower with bivalirudin. And so basically bivalirudin was a more effective anticoagulant. Let me just show you the tables here. So in terms of the in-circuit thrombosis, what you see here is a statistically significant p-value in favor of bivalirudin. They had less in-circuit thrombosis with bivalirudin. The rates of changing of the membrane oxygenator were much lower with bivalirudin. Longevity of the membrane oxygenator were much better with bivalirudin. Not only that, bleeding complications were much less with bivalirudin. So it was all in favor of bivalirudin. Patients on bivalirudin received less blood, less FFP, less platelets, had longer lifespans of their membrane oxygenator, longer lifespans of their ECMO circuit. Some of the secondary outcomes here are displayed here. Didn't really reach statistical significance. Maybe a bit of a p-value that's significant for survival at 1 year in favor also of bivalirudin. It's unclear where that came from. But regardless, what I'm going to say here is that this study, even though it's a retrospective cohort study, it really has affected my practice. And I've been more recently using bivalirudin as a primary anticoagulant, not just in patients with HIT, to see, and I've seen that the ECMO circuits and the membrane oxygenator efficiency are maintained for much longer. What they concluded in the study is that bivalirudin decreased the number of ECMO circuit-related thrombotic events as significantly, and it also decreased the amount of blood and blood products given. So even though bivalirudin is a bit of an expensive drug, because it was associated with less blood and blood products, despite the higher cost of the medication, use of bivalirudin may actually be cost-saving because you end up transfusing much less with bivalirudin. So I was in a conference more recently, an ECMO conference in Phoenix, in Arizona, and they did just a bit of a poll of the audience. How many people here across this room have switched over to bivalirudin as the primary anticoagulant on ECMO? And I was surprised when I looked around and I found that half of the room had switched over to bivalirudin as a primary anticoagulant, which I thought was, okay, wow, this may be actually coming. So I think bivalirudin may be coming here up the pipelines as something that is more of a mainstay anticoagulant. All right, so these are all the studies that I wanted to share with you today, and I will summarize by saying in the first study, we demonstrated that early unselective peripheral VA ECMO in all comers presenting with AMI cardiogenic shock with planned early revascularization did not improve 30-day mortality. Routine use of the Impella in patients with STEMI-related cardiogenic shock actually did reduce the risk of death from any cause at 180 days, provided you select the right patients, provided you choose patients who don't have RV failure, who are neurologically intact. The third study demonstrated how patients on peripheral VA ECMO, well, it didn't really demonstrate anything, the third study, because it really didn't answer the question whether we should unload the LV early on or not. It was a hard to interpret study, but we're still waiting for more evidence on that side. I still use a watchful waiting approach. And the last study actually, even though it was a retrospective study with limitations, it actually showed that routine use of bivalirudin for ECMO anticoagulation may be superior to heparin. With that, I will conclude. Thank you very much. I think I went a little bit over time.
So, Ahmed, there were two questions in the chat. One here is there any difference in MCS, trying to exactly understand, but metallic or aortic, mitral aortic metallic valves related to MCS? I'm not exactly clear what's being asked, but.
Right. So in terms of maybe we're looking at does having a mechanical mitral valve or aortic valve really affect your choice of MCS device? And definitely it does. So if that's the question, if you have a mechanical aortic valve, then that's a contraindication to getting an Impella. You should not be putting in an Impella in somebody with a mechanical aortic valve, definitely. The other thing is, what about VA ECMO? Can you put in somebody with a mechanical aortic valve on VA ECMO? Yes, you can. It's not an absolute contraindication. What you need to be wary of, though, in this setting is that stasis around that mechanical valve can happen. Now, remember, you're bypassing a lot of the pulmonary circulation. You're bypassing the blood going through the left heart. And so you're really withdrawing blood from the right atrium and pumping it back into the descending aorta. And so if you have a lot of stasis around that mechanical aortic valve, then you can start developing clots, and that can have really bad consequences in terms of embolization. So is having a mechanical aortic valve, is it an absolute contraindication to being put on peripheral VA ECMO? No, it's not an absolute contraindication. But what you need to be wary of is stasis. You need to be very watchful and careful that they don't start clotting off that aortic valve because of bypassing all the flow going through and lack of flow going through the aortic valve. I hope that addresses the question.
Then there's a second question about, are there any studies that put a timeline for recovery when you're considering, well, this is interesting because it says durable MCS. We didn't really talk about durable MCS, but so I'm not sure if they mean LVAD or we're referring back to percutaneous.
Right. Yeah, so when it comes to durable LVADs, I'm not aware of any studies that have looked at recovery from after getting a durable LVAD. Durable LVADs are usually put in either as a bridge transplant or as destination therapy. Recovery is possible after getting a durable LVAD. I've certainly heard of it. I've seen one patient that I heard actually did recover after a durable LVAD. But are there any studies that have looked at the rates of recovery? Maybe I'll defer to my panel here, because I'm not aware actually that there is a study that have looked at the rates of recovery after getting a durable LVAD. Maybe Dr. Ricardo Gallo can pitch in.
I'm not, but I'll tell you, I have a 10-year-old Heartware. They were taken off the market 4 years ago in the world. And that patient's been on Heartware for 10 years, and we are transitioning that patient now to transplant. That's a very unusual case.
Yeah, right. Yeah,
I think that was not the question. I have a feeling that the question was, how long do you wait for a recovery before you consider going on a durable LVAD?
Right.
Once you have implanted the short-term VAD, I think this is what the question is probably all about. I mean, question of the century. Because we really don't, there's no easy way to answer that if that's indeed the question. Could the person who asked the question just confirm that I'm addressing the right thing? I can tell you our protocol. We usually at about a day 3 to 4 of VA ECMO, we're looking for the next step, and that next step is usually a short-term device. After the short-term device has been implanted, whether it's a microaxial Impella or whether it's Levitronics, which is usually what we use here, the CentriMag, we tend to make a decision in the next week or two whether we're proceeding with the durable device. This is all obviously based on the patient demographics, the pathophysiology, and so on and so on. But I think the timeline ECMO to physiologically appropriate short-term device is probably between 3 to 7 days. And then in the next 7 to 14 days, you should be making a decision whether the durable device is appropriate for that patient. If there was no ECMO, obviously you eliminate the first part. So you implant the microaxial device, then you wait, for the device is approved in Canada for 7 days as it is. I know patients who've been on Impellas for months. And then you wait essentially to see if the patient is a bridge to recovery, bridge to intermediate term device, long-term device, or transplantation. But I think you should be making those decisions at a 7-day mark going forward rather rapidly. That's what I think the question was.
Okay. Dr. Gallo, you have a question?
Yes, a comment. Ahmed, we are neighbors. I work here in Jeddah, in Saudi Arabia. And I was surprised, not surprised, but that you had the same results with ECMO or no ECMO in acute myocardial infarction with less than 45 minutes cardiac arrest. So a question for Dr. Ahmed is, do you think that we are overusing the ECMO in desperate situations or a wrong indication? Because, we have the same result with ECMO and no ECMO. So what he shows. So do you think that we are overusing the ECMO in desperate situations that shouldn't be used? I don't know. It's a question for Ahmed, Dr. Ahmed.
I think it's a great question. The study really didn't show a difference. All these patients were cardiogenic shock patients, CHI class C, D, and E. And these were critically ill cardiogenic shock patients who were planned with early PCI. Are we overusing VA ECMO? It's hard to actually say that. Well, at least in my institution, we're actually not pulling the gun on VA ECMO very aggressively in this patient population specifically. Patients who are sort of Intermax 1 and critical cardiogenic shock, or Intermax 2, they're sort of slipping fast and requiring escalating doses of inotropes. I would still, in my mind, look and assess whether they would warrant VA ECMO. Mind you, this is, if you look strictly at what the study showed, there was absolutely no difference. So perhaps if you're quick to pull the trigger on VA ECMO, then you may be actually overusing it. The study showed no difference. But if you're really very closely watching the trajectory within the first 6 hours and pulling the trigger on VA ECMO in patients who are slipping fast, and in my opinion, that still constitutes a reasonable indication for VA ECMO, provided that they're neurologically not, they don't have multi-organ failure and other factors that would contraindicate putting on a patient on VA ECMO. That's been my take on it, and I'll open it up to maybe you, Dr. Gallo, and Dr. Scott, and Samakovic, if you have any other takes on it.
Well, thank you for your genuine answer. The thing is, sometimes, I am a cardiac surgeon. I'm an intensivist. I am not a cardiologist. But sometimes we get calls from the cath lab, and we feel that sometimes, unfortunately, we had to give up, unfortunately. But we use the ECMO when we know there is no way back. So that was my question. Now, when you present that the result is the same with ECMO or without ECMO, also open a big question for myself to see if we should put the patient on ECMO or not. We have to recognize that sometimes we use the ECMO as a desperate situation. The patient is gone and we put it in ECMO, and we may know that the patient is not coming back, but we put it in ECMO anyway. So when you present that result, I was, surprised, and maybe, I don't know, we are overusing the ECMO sometimes when it's not indicated. So that was a question. So thank you very much, Ahmed. Thank you very much. Thank you.
No, thank you.
Okay, and there's a couple more questions. I'm just trying to screen and see what fit into really what we discussed. So Okay, Faisal, and pardon me if I don't say the name right, but Altatar said Impella versus IABP for routine LV loading head-to-head trial versus wait and see. And I think, that's kind of right in the zone with what you presented. So you want to just mention anything about that, Amit?
Yeah, there's, I'm not aware of any RCT. There's no RCT that actually has done a head-to-head comparison of Impellas versus balloon pumps. But I will say this, balloon pumps will give you a maximum forward flow augmentation of about 1/2 to 1 liter at the most. Balloon pumps will reduce your afterload, will make it easier for the heart to pump forward. And so 1/2 to 1 liter of augmentation of forward flow is what you can get with a balloon pump. And so it's a milder form of support when you compare it to Impellas, which can, Impella CPs can give you upwards of 3 liters of flow. Impella 5.5s can give you up to 5.5 liters of flow. So you can really, fully take over left heart function with an Impella. Whereas with a balloon pump, you're basically supporting the LV, but it's a milder form of support. So there are certain situations where we will gravitate towards a balloon pump. Patients with a mechanical complication of MI, like a ruptured pap muscle and severe MR, we tend to gravitate towards using balloon pumps. Patients with ventricular septal ruptures, we tend to gravitate towards balloon pump. But still, you can still use Impellas in these patients successfully. I mean, it used to be thought that VSRs are an absolute contraindication, but actually, no, there is a big case series that has been published that if you keep the P level low enough with an Impella in a VSR, you will not actually shunt over blood. You're just going to decompress the LV enough to support the LV as a bridge to surgery. So anyways, balloon pump versus Impella, no head-to-head comparison. Do we have a strong evidence for the balloon pump in cardiogenic shock? No, we don't. The SHOCK 2 trial actually showed no difference in using a balloon pump versus not. Do we have strong evidence for the Impella? Well, now with the Danger Shock trial, we do have a positive study that has showed that the Impella actually does improve mortality. And so I must say, just look at your patient, and if they're really an extremist and it's isolated LV failure, and you want full support of the LV, then the Impella will give you better augmentation of cardiac output. Balloon pumps will give you a bit of a less sort of an augmentation. However, bleeding complications, what I've seen is much higher with Impellas. So you take one advantage, but not the other. Yeah. Yeah, go ahead.
Okay, no, I'm sorry. So interesting question, actually 2 interesting questions, but Gordon, I think this one is probably best for you. Bival and first-line agent in cardiac surgery. So I'm wondering if that means intraoperative or means when the, as an initial.
Oh, sorry, I didn't understand. What was the question?
So can Bival be used as a first line in cardiac surgery? And I'm not sure if we mean cardiac surgery as the actual procedure or in this.
Or following.
Yeah.
So we tried alternatives to heparinization in patients who have had documented hits, severe hits, and things like that. It never went well. I can tell you that for sure. The alternatives to heparin I'm assuming the question is on cardiopulmonary bypass, full heparization to perform heart surgery, rather than ECMO post-heart surgery on biliverdin. So I don't think I would be strongly opposed to giving biliverdin after cardiac surgery just for the ECMO anticoagulation versus giving it intraoperatively in large dose to maintain cardiopulmonary bypass anticoagulation. I don't know of it ever being done in this center, certainly, and I certainly have never talked about this to anybody. And the experience here has been terrible using alternatives to heparin on cardiopulmonary bypass.
Yeah, same here. I think if anything, we still use heparin, but we mitigate the risk.
Exactly.
The same with pheresis or
Exactly.
Yeah. Okay. So I think that's standard, whether it's in the U.S. or Canada or pretty much anywhere from what I've seen. I guess we'll take two more questions. In a patient with severe AR, so how would you unload? And my answer there is you have to fix the AI before you consider anything. And so maybe that's a TAVR in a high-risk patient. Again, I don't know if you guys have any other thoughts, but certainly I'm not going to put a device in somebody who's got wide open AI. We're going to fix them surgically.
Correct. Yeah, absolutely. 100%.
Yeah, and I'm definitely not going to put somebody on ECMO who has wide open AI. I mean, that's just a death sentence.
Yeah.
Okay.
So,
Perfect.
yeah.
The question was, okay, so this is talking about, I guess, massive PE, I'm assuming, even though we're not talking about PE directly. And so they asked if VA ECMO or TPA with PE with RV strain, which I'm going to take as a massive PE. And just from my aspect, so VA ECMO is not a treatment. It's just a salvage modality or stabilization modality to allow you to initiate proper either mechanical intervention or anticoagulation to deal with the clot that is causing the obstructive shock. And so, you have to make a decision if the patient's a ECMO candidate or really needs it, or you could tolerate TPA or whatever other agent you might be using and what other dosing strategy. These things are best done by organized PE response teams or PERT teams. We have a very large multidisciplinary organized program here at Jackson Memorial in Miami. And, this is something that we discuss through a chat, secure chat, for confidentiality, in essence, where interventional radiology, cardiac surgery, critical care, usually us, cardiac critical care, and a variety of folks are on there, trying to sort out the best situation for the patient, depending on where they are and what their comorbidities are, their age, et cetera. I don't know if you have any further thoughts on that.
No, that's excellent. Absolutely. 100%. Thank you. Thank you for that.
There's a detailed question about unloading while we're looking at this. So, okay, thanks all. Question, given the significant crossover in the early unload trial, many subjects included an intervention arm with a large multi-center cohort, suggesting a mortality benefit. Do you think we need to lower the threshold to proceed with LV loading? I guess that means an earlier intervention or maybe not wait till things get so bad. But I think that goes back to the older standard, wouldn't you think, Ahmed, where we were trying to unload everybody and now we're trying not to do that?
Yeah, I agree. I mean, yeah, you're right. I mean, a while back, everybody was looking at, or everybody was unloading as quickly as aggressively early on. That there was a study that came out, a retrospective cohort study in Circulation, I believe, that looked at ECPella versus ECMO alone. They basically had patients unloaded with an Impella in addition to VA ECMO compared to just VA ECMO. And it showed an improved chances of myocardial recovery in that retrospective study. But there's so much complications with that approach. And the benefit is still not very well established. If you were to unload everybody right aggressively right from the start, that's not been my approach, and I'm happy to hear that my approach is similar to other places where we watch and wait very closely and see if the LV starts distending, we intervene right then and there. But if the LV can tolerate it fine, can take it okay, then no need to really expose the patient to an intervention with its own risks when really the indication is not there.
We follow the same strategy. And I think also that trial, if it's the one I'm thinking of, because there's so many replications of things, the stroke rate was 3 times higher with the ECPella, and also the limb ischemia was significant because you're adding a whole nother set of, obstruction into the limb. So I think that's a pretty reasonable thought.
Yeah.
I think we covered, without repeating anything, all the questions.
Okay. I want to thank you all for attending. I want to thank all our moderators, Dr. Scott, Dr. Gallo, Dr. Ashwak, Mahdali, Dr. Amr. I want to thank you all for attending. I think the attendance here was really quite remarkable today. We had 236 attendees, which is really quite impressive. And I hope you visit the WICCM landing page and see the Cardiac Critical Care Fellowship, explore what that has to offer. And I'm glad there was a very interactive Q&A session here, and thank you all for joining, depending on where you are.
Thank you. Thank you, Ahmed, for the excellent presentation. Thank you very much.
Thank you. Thank you, Dr. Scott. Thank you, Dr. Gallo. Thank you all.